I now ask Dr. Robert Matthew Reveille to join us at this virtual podium. Dr. Reveille is the Chief of Gastroenterology at the Rocky Mountain Regional VA Medical Center. We are so lucky to have him at the helm. Really, after decades of clinical experience in the community, Dr. Reveille will be giving us all the tips and tricks in managing fecal incontinence, a problem that is seen across many specialties. So thank you so much, Dr. Reveille. If you are muted, please unmute yourself.
Can you hear me now?
Perfect.
Great. Thanks very much to the organizers for the opportunity to present a topic that I've spent pretty much all my clinical and academic career on, the topic of fecal incontinence. Not necessarily the greatest breakfast talk, but nonetheless, we'll go ahead. By way of disclosure, I do not have any financial disclosures, but I am a member of the International Anorectal Physiology Working Group, paper which we will refer to during this talk. For 30 years, I spent time teaching manometry and developing products and techniques with Diversitech Sandhill, a local Colorado company, a leader in motility. So fecal incontinence is defined as the involuntary passage of inability to control discharge of fecal matter through the anus. I hope you don't have this particular bumper sticker on your back window. Now think about bowel control. One of the things that takes us from being a toddler to being an adult is our ability to control our bowels and our urinary excretion. So one of the first signs of an independent human being is learning bowel control. Toward the back end of life, fecal incontinence becomes a problem, and it's really a big emotional hit to many of us. The prevalence of fecal incontinence, about 18% of the adult population has fecal incontinence. Almost 3% report daily incontinence, 4.5% weekly incontinence, and monthly or less, over 7%. So this is not a small inconvenience. This is a huge hit. Symptomatic fecal incontinence occurs in about 20% of women who also present to their primary care gynecologist with complaints of urinary incontinence, pelvic organ prolapse, or both. And in fact, when you look at the prevalence of fecal incontinence as we study these patients, the reverse is actually more impressive. For those patients presenting for evaluation of fecal incontinence, 40% actually have double incontinence. So when we ask about fecal incontinence, we always ask about urinary incontinence as well before we approach our treatment. It's the second most common reason to place a loved one in a nursing home in the United States. So the financial impact, the social impact of fecal incontinence cannot be understated. More than half the residents in nursing homes actually have fecal incontinence as one of the medical problems. And in 2012 dollars, the cost for care of fecal incontinence on an annual basis was over $4,000. Now, I need to come back and give you an anatomy lesson first. The anal sphincter is unique and extremely complex. It's a precisely integrated control mechanism where the involuntary nervous system, that is the autonomic nervous system, and the somatic nervous system come into interplay. There is no other region of the digestive tract that actually has this tightly integrated function. In fact, throughout the body, this is one of the most important and highly integrated areas of the human body. Now, as a matter of anatomic pearls, there are three main mechanisms to restoration and maintenance of continence. The pelvic floor itself, the muscles of the pelvic floor and the nerves, principally the pudendal nerve, control the neighborhood by which the anal sphincter has to do its work. The puborectalis, arguably the strongest muscle of the pelvic floor, is innervated by sacral nerve roots. But more importantly, the intrinsic anal sphincters, what we're talking about here, the internal sphincter is really an extension, a specialized extension of the circular muscle of the rectum. And at the very bottom, it becomes thicker and is under complete autonomic control. No matter what you do, you cannot tell your internal anal sphincter to contract or relax. Invested around this are actually three bellies of something we call the external sphincter complex. And we now know from new anatomic studies using high-resolution MRI that the deep portion is actually an inferior extension of the puborectalis. So these muscles work together to voluntarily close and control, as well as the external sphincters. These would be your pucker muscles right here. An important anatomic delineation is this dentate line. Above the dentate line, rectal mucosa, it's insensitive. Below the dentate line, it is actually skin. It's the second most sensitive area on the external side of the body. The nerve endings here are richly dense, and so sensation is critical to understanding. As waste begins to enter the anal canal from above, the internal sphincter relaxes, the skin is contacted, and the human being then knows, hey, this is gas, I can let it out. This is diarrhea, I really need to pinch and hold. This is a bowel movement. I'm listening to Dr. Reveille talking this morning, and I'm going to have to hold back just a little bit longer. So a quick anatomic review of the internal sphincter. Now, this working group that I've been involved with has developed a new paradigm for testing and understanding of all the components of pelvic floor control. The original paper was published in August of 29 after over 4 years of work. And I want to highlight three main aspects of altered physiology, the ones we're going to talk about today. Sphincter tone, the resting contraction of the internal and external sphincter. 70% of the resting tone is due to contraction of the internal sphincter, that which you and I cannot control. We describe hypotension, normotension, and hypertension. The voluntary contractile activity of the external sphincter and puber rectalis working in concert to hold back waste. We describe hypocontractility, or weak squeeze, and normal contractility. And last but not least, the concept of anorectal sensation, a very key component of maintaining control, particularly in a public place. We describe rectal hyposensitivity, normal sensation, and rectal hypersensitivity. So these concepts have now been qualified, and this is the subject of ongoing research to look at outcome studies using these parameters. If you're a gastroenterologist or you're running a pelvic floor a diagnostic center, I would encourage you to grab hold of this paper and begin to report using these new patterns of physiology understanding. So let me break it down. We don't want to use urinary incontinence as the comparator because I think fecal incontinence is more complex, but just for the basics, taking a history, we describe three basic types. Passive incontinence, the involuntary discharge of stool or gas, with or without awareness. Digital examination and manometric findings show low resting tone, often an anatomic defect, particularly in a multiparous female, and they often have impaired anorectal sensation. Compare and contrast that with urge incontinence, the discharge of fecal matter despite all attempts to retain the bowel contents. An example of this might be somebody with diarrhea, predominant irritable bowel syndrome. Their sphincter may be normal, but they cannot contract firmly enough to overcome the force of the stool being propelled by the sigmoid colon, and they often don't make it to the bathroom. I think most of us can recall a diarrheal illness in our lifetime where we didn't quite make it, and we know how embarrassing that was on a one-time event. Digital examination and manometric findings, typically a normal tone, but when we ask the patient to squeeze, it's weak or it gives way. We should be able to sustain a contraction for at least 30 seconds to retard the egress of stool and have control in a public setting. They may have rectal hypersensitivity, again, an irritable bowel patient or somebody with inflammatory bowel disease. And the last type is the one that often is what presents to us. And that's what we call the seepage, the leakage of rectal contents not related to a bowel movement. And I want to point out, despite the anatomic things that we see, we should also think about hemorrhoids or rectal prolapse, anal fissures or fistula where the stool bypasses the anal sphincter. And frequently in this type of fecal incontinence, there is significant sensory impairment. If you are 65 years or younger and I inflate a 10 cc balloon in your rectum, you should be able to perceive that there is distension happening at the anal sphincter. The causes of fecal incontinence are numerous, and I don't want to go into great detail, but let's just look at a few of the broad categories. Obstetric injury, not that caused by an obstetrician, but that related to having a pelvic floor vaginal birth. Previous anal surgery, such as sphincterotomy. Diabetes mellitus becoming a much more prevalent problem as the diabetes incidence increases. Proctitis and inflammatory bowel disease. We should also include the microscopic and collagenous colitis variants in this category. Anorectal trauma, radiation injury in women. It was for cervical and uterine cancer. Now we see an increasing number of male subjects who have had radiation therapy for prostate cancer and are now presenting with fecal incontinence. A whole host of neurologic disorders, central and peripheral. Keep in mind that Colorado is the principal state, has the highest incidence of multiple sclerosis in the United States. Won't go into the details as to why, but suffice it to say that that should be considered in a differential diagnosis. Irritable bowel syndrome, and believe it or not, chronic straining at stool. Straining at stool for 30 years can cause sphincter damage and result and the paradox of fecal incontinence. Now, incontinence is often multifactorial. They may have multiple diseases that contribute. They may have had multiparity. They may have had an anal sphincterotomy. So a history taking is very important. The mix of symptoms is also important. We may have a young female multiparous with irritable bowel syndrome who has seepage at rest, and when she runs, goes on a run, she has urge incontinence. So the evaluation needs to be tailored to try to pick up exactly what's wrong with the physiology of the anal sphincter. Currently, high-resolution anal rectal manometry is the gold standard for testing, and the testing often confirms your clinical suspicion, particularly in my world where I've been doing this for quite some time, and I can often predict what the findings will be, and then I can start therapy. I can't overemphasize the importance of anal rectal sensation, what I call the radar screen concept. Two phrases say it all. If you can't feel it right, you can't squeeze it tight. An example of anal hyposensitivity. If you can't feel it in time, you can't squeeze it in time. Once the anal canal distends from content, you have about 5 seconds to make a conscious decision. If you have a delay in sensation, it's likely that you will have an egress of waste from the rectum that you didn't prefer. Interestingly, 25% of all incontinence is actually due to a sensory impairment problem. So let's look at the spectrum of interventions for fecal incontinence. I put this on a big, broad timeline because things have developed rapidly. I'm going to highlight some of the new devices that are on the market that are being deployed, but we want to talk about some fundamentals. On the left side of the spectrum, we have alteration and just changing bowel function, bowel habit training, being sure that the elimination is complete in the morning so that there's nothing left for seepage or leakage during the day. The use of medications to change sphincter function, to slow the egress of stool down the colon so that it's firmer by the time it reaches the rectum. The human sphincter was not designed to handle liquids, so a firm stool is really what the goal is here. The next group, and this has been arbitrarily placed into steps, is undergoing retraining or rehabilitation to try to improve sensation and squeeze strength. Under the third category are inserts, implants, and devices, which will be mostly show and tell for the purpose of this talk, and I will not move on to talk about the role of surgery on this talk today. First step, frontline, primary care, basically anybody seeing patients with fecal incontinence. Alter the colonic function. That may be all you need to do to make the patient happy. We talk about reducing fecal water so that there's less water in the rectum, less residue for the opportunity for seepage. Bulking agents, I'm careful to use agents, not laxatives here. Bile salt binders, anti-motility agents such as loperamide, and something I've learned from patients over the years is after their morning bowel movement, they rinse their rectum using a baby bulb syringe with 2 to 4 ounces of tap water to clear the rectum of all residual content. And oftentimes they'll be dry throughout the day. So always listen to your patients and get some tips. Slow down the transit, anti-motility agents, including loperamide and Lomotil, and also an interesting study in the New England Journal done over 20 years ago with the geriatrics group of patients, small doses of amitriptyline to enhance the sigmoid reservoir function and not allow liquid to gain access to the rectum, leading to seepage. Anti-motility agents, again, to slow the sigmoid colon function. And it's interesting, if I tell you to contract your anal sphincter, you can't slow your sigmoid colon, but one of the benefits of neuromuscular training over time is that the sigmoid colon holding or braking function actually can be improved. And last but not least, for patients who may have a component of overflow incontinence from fecal retention, get them to have a good quality elimination every morning, eliminate the impactions that may be occurring. And my caveat there is promote a BM in the AM after your morning meal. Step 2. Neuromuscular retraining. What is it? It's a form of physical therapy. What is it not? Biofeedback. That term has gained disfavor with the insurance industry for over 40 years, and it really isn't biofeedback. We're learning conscious control over conscious functions. Now, what can we accomplish with neuromuscular retraining? Modest improvement in resting tone, but not due to the internal sphincter. We're working the external sphincter. It's bulking up and its tone is enhanced. Improving squeeze strength for those people who have anal hypocontractility. Improving the awareness of rectal filling, that is, tuning up their radar screen and reducing the opportunity for passive incontinence and seepage. And restoring the external sphincter contraction every time the rectum distends. That's an automatic function that we're not normally aware of. that reduces passive fecal incontinence and seepage. How good are we at doing this? I've done this for many years and developed protocols. On average, we're going to be doing 70 to 80% in my hands to improve the patient's quality of life and negate their fecal incontinence complaints. Now, moving along, over here is the inserts, implants, and devices. And all of these are now FDA approved. I'll just show you some of them that are commercially available, and you can actually order them for patients who may not be responding to step 1 therapies and may have undergone a trial of neuromuscular retraining and are still having problematic fecal incontinence. On the left is a very commonly used device. We're actually able to get this to the VA now. This is called Renew Insert. After the patient has their elimination, they may take a rinsing enema, and this single-use disposable device is gently inserted into the rectum and provides a barrier to leakage. It won't help with an urgency incontinence, but it will help with leakage and passive incontinence. On the right side, this is the Coloplast Peristine device. Again, a single-use device which is inserted, the cap is inverted, and this provides a nice seal for many patients. A device that was developed several years ago for urinary incontinence then was FDA approved for fecal incontinence. This is called Celesta. This is a dextranomer of hyaluronic acid. So it's really a basis of collagen. And this is placed endoscopically in 4 quadrants, about 3 to 5 millimeters above the dentate line, below the mucosa and into the muscle wall. This then cures over the course of approximately a week and creates a bulking agent in the anal sphincter. Complications are rare, but bleeding and occasional fever are reported, and patients who have diabetes or have had radiation therapy, you should probably not use this. And this is an anoscopic view showing left lateral, right lateral, anterior, and posterior. This can be repeated at 6 weeks, and at 6 weeks we would then inject at the opposite corners so that we have basically 8 ridges of high pressure zone created by the Celesta polymer injection. This is a new device on the market. I'm sure gynecologists are aware of this. This is called the Eclipse device. It is actually a vaginal insert. It's a soft device that's inserted, attached to an inflator. And you can see here that in the posterior vagina, the balloon actually occludes the distal rectum. It really doesn't do much for the sphincter, but it does prevent stool from entering into the distal rectum and entering the anal canal, an opportunity for incontinence. This is the Phoenix magnetic bracelet. This is very akin to the Lynx bracelet that we're using for patients with reflux procedures. It's neodymium magnets that are actually implanted surgically and allows the sphincter will remain closed in such a time as the patient has a bolus of stool and generates a pressure. You have to generate a pressure over 40 to 45 millimeters of mercury, a gradient across this. The magnets pop open, elimination is accomplished, and then the sphincter closes. Obviously, because it's an implant around the rectum, one of the big complications here that we worry about is the issue about erosion and or infection. And perhaps the most popular and well-studied device implant is called InterStim. This is sacral nerve stimulation. Patient undergoes a temporary trial of stimulation of sacral nerve roots 2 and 3. This stimulates the sphincter, enhances sensitivity, and even in patients who have a sphincter gap, provides a great benefit for incontinence. If they have a 50% reduction during the first 2 to 6 week trial, then the permanent device is implanted, and this looked very much like a pacemaker. So let's talk about how we approach this. Because the causes are often multifactorial, the mechanisms are often multidimensional, we have to think about a combination approach based on history and based on testing. Does the patient have sphincter hypotension? If so, what can we do to enhance the basal pressure? Well, now it's interesting because a lot of medications can be taken orally. Sympathomimetic drugs like neosynephrine, ephedrine, things like that, could enhance the sphincter, but in order to improve sphincter tone, you'd actually have to take extraordinary doses and probably be extremely hypertensive. So we're at a loss with oral drugs, with the exception of the following, and you should keep in mind of this. Loperamide, Imodium. This drug has actually been shown in a study in diseases of colon and rectum years ago to enhance internal anal sphincter tone for approximately 4 hours. So it buys patients time. The way I approach this is they have a morning bowel movement. They may do a rinsing enema. they take 2 milligrams of loperamide. If they plan on an outing in public where they'd be concerned, another 1 to 2 milligrams is taken prior to the outing to give them 4 hours of confidence in the public sector. The maximum dose used to be 32 milligrams a day. I've highlighted this is up to only 16 milligrams a day now because of concerns about cardiac toxicity and long-term use. You can use a bulking agent such as we've shown earlier. You can use the Eclipse device to increase the pressure above the sphincter and retard stool egress. And then soon, we're looking to see some reports of prospective studies with the Phoenix device to see whether that will actually provide patients an improvement. It ought to, because we're dealing with sphincter hypotension. Retraining is very effective, and if patients have irritable bowel syndrome or they have inflammatory bowel syndrome, they release high levels of histamine, and that's the basis for the urgency. So you can actually use antihistamines, preferably the newer generation non-sedating ones, to reduce urgency and reduce the incidence for incontinence. And then, of course, after the bowel movement, we can use an anal plug. If the patient has a palpable defect from a previous tear, we still feel that surgery should be considered. Do they have sphincter hypocontractility? We want to strengthen the external sphincter. We bring things together, and then we put them through a rehabilitation program. Interstim implant is also an option for these patients. And lastly, do they have rectal hyposensitivity manifested by incontinence or seepage, or are they hypersensitive? We can retrain the radar screen using sensory retraining on either end of the sensitivity spectrum. Interstim is beneficial in those patients with hyposensitivity and hypersensitivity antihistamines, and if they have IBD, topical anti-inflammatories. So in summary, fecal incontinence has a significant impact on quality of life. But there's much we could do about it. We don't handhold anymore. We could do something. Consider the 3 main types of fecal incontinence when taking a history. Altered anal rectal sensation is an important contributor. Fecal incontinence causes are often multifactorial. The mechanism is often multidimensional, and treatment requires a combination approach. High-resolution manometry is useful in characterizing what has gone awry with the incontinence mechanism and where intervention should be directed. Remember the first step in management, attempt to alter colonic function. You may be a hero early on in the game. Neuromuscular retraining benefits the majority of patients who do not respond to first step management. And new devices, such as the ones I've shown you here, offer significant hope for patients with more severe forms of fecal incontinence. But as of today's lecture, we are missing randomized controlled trials and comparative studies. Thank you.
Thank you so much, Dr. Reveille, for this very stimulating this morning. Perhaps a silver lining of this webinar platform is that people can take you up on your medical recommendation to promote a BM in the AM. As I ask you to unshare your slides,